Good morning. I am honored to be here, and I was really asked to frame it, and I think Drs. Cada and Gracia have framed it much better than I can. So I'm going to skip through some of my opening comments. Now, Tiffany mentioned about the hip titles. As you can see, I'm not of the generation. I still see that as pound instead of hashtag. So I always have to kind of pause and say, that's hashtag. But then the more I think about it in terms of the struggle, maybe it should be pound, 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 pound. We really need to pound the message home. And I think that we've heard how important this is, that the struggle is real. And I think that, so I'm going to do just a couple of opening remarks before I introduce this really supreme panel. I think you're going to be really enriched by what they bring and share with you. Let's see. I thought I would at least start, though, with a definition of mental health. We've talked a lot about mental illness or mental disorders, and that is important, but this is the World Health Organization definition of mental health. A state of well-being in which every individual realizes his or her own potential, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make a contribution to her or his community. That probably is similar to, I think, SAMHSA's recovery model of what happens when people have an addiction and you want them to fully recover. So we're really talking about how everybody can live a really self-realized life and contribute to that community and to their families. Mental condition. Half of us, I do like to personalize it, will meet criteria for a diagnosable mental health condition at some point in our lives. 25% of us by the age of 14, and about 50% has been estimated of these conditions begin in childhood and adolescence. So this is very personal for all of us. I think all of us, as has been suggested, know someone, and we need to know what that frame is, and that is something that we should acknowledge and not necessarily, we can't kind of run away from it because it's going to follow us there. These are pictures, and these are pictures of all kinds of affect and emotion. And I chose this because it shows everything from depression and suspicion and guilt and embarrassment and ashamed and rage. And all of us, I think as parents, all of us know that most of us have to go through and experience all of these. How many have experienced all of these? We all need to experience it, and I think it helps us to become empathetic. It is probably necessary. As a parent, we don't want our children to necessarily experience all of these things, but we know it's necessary to be unhappy at times. It makes us have empathy for other people, and it helps in our growth and development. I think the one thing, I'm in charge of health disparities here at APA, and Dr. Garcia mentioned some things that we talk about, implicit bias in school, suspensions of preschoolers, and what happens with Black males. And we talk about obesity and stress. So there are a number of things we talk about. The one thing that I think that our message is that for all of these things, everybody needs to visit all of these emotions, but we don't need to take permanent residence in them. And for some of us, we have almost taken permanent residence for things that can be changed. And I think that that's the bigger message that I think that we'll be talking about. It is that we know that all of us have to experience all of these emotions as a part of life, but for some of us, conditions almost force us to stay too long in some of these places. So in health disparities work and in this kind of work in general, one of the first things that we need to do is to document and understand. And that's what this first panel is going to do. It needs to document where we are within our own communities and to understand why we're there, to lead to how we can get out of these permanent residences in some of these places that we find ourselves. So our speakers today will start the conversation with that, some startling statistics and some thoughtful perspectives. They'll describe the landscape. Now, they only have about 7 or 8 minutes to talk about their whole communities. I could spend about 7 or 8 minutes just talking about myself and one condition probably, but one to describe the landscape of mental health in their respective communities. They'll talk about mental health. I've seen their presentations as well as mental disorders and concerns. And they'll offer ways of understanding causes and needs through their theories, conceptual frameworks, or either questions that still need to be answered. So I know most of them, and I've worked with most of them, and I know what great, outstanding scholars they are, how passionate they are about their work and what they'll bring to you. I'm going to introduce each of them first so that they will have, they can start talking and I won't have to stop and do that again. So to my left is Kevin Nadal, who's a professor of psychology at City University of New York. He received his PhD from Columbia, and he has been head of he's president of the Asian American Psychological Association. So I'm not going to read everything up here. But he will be followed by Tama Bryant Davis, who I've known for a very long time. She's an associate professor of psychology at Pepperdine University, where she's also director of the Culture and Trauma Research Lab. And she's past president of APA's Division 35, which is Society for the Psychology of Women. This is my first time to meet in person Jeanette Castellanos, who's a tenured lecturer for the School of Social Sciences at UC Irvine. She received her PhD and MED from Washington State University, Pullman. And she's the executive director for the National Latina Psychological Association and was one of the founding members of the California Latino Psychological Association. Jackie Gray serves on our National Steering Committee on Health Disparities here at APA, and so I've worked with her for a few years. She's a Choctaw Cherokee Research Associate Professor and Associate Director at the Center for Rural Health at the University of North Dakota, and is Director of the 7th Generation Center of Excellence in Native Behavioral Health at the School of Medicine and Health Sciences. So this is how we're going to work. We're going to let each of them present in order. After their individual presentations, you'll have about 2 or 3 minutes for clarifying questions. If you have a clarifying question only, you can ask it at that time. Following all of their presentations, we will have a longer question and answer and discussion period. Okay, so Kevin, can you help me get rid of this? Are you loaded up already?
So, that just has to go together. Great. Thank you, Dr. Beatty, and thank you to Dr. Townsend and for all of you for being here today. As was mentioned, I only have about 7 minutes to talk about millions of people, but I hope to get through this as quickly as possible, and I'd be more than happy to share this PowerPoint with everyone as well. So I'm here to talk about the mental health disparities of Asian Americans and Pacific Islanders. So just some cultural context. Asian Americans are the fastest growing racial minority group here in the United States, and it refers to people of 40 distinct countries of origin who now live in the United States. We represent about 5% of the US population, and we're projected to increase to 40 million by the year 2050, or 9% of the total US population. In some parts of the country, like in California or New York, Asian Americans make up to 15% of the population. So that's about 1 out of every 6 or 7 people in California or in New York City who are Asian American. Pacific Islanders are oftentimes grouped into this umbrella category as well. Native Hawaiians, Pacific Islanders make up about 1.4 million people of the US population. By the year 2050, it's projected that there will be 2.6 million people of Native Hawaiian or other Pacific Islander ancestry. And so when we talk about these groups, it's really important to recognize the heterogeneity of these populations. We're talking about 40 different distinct ethnic groups who've been lumped into this umbrella category. When I talk about Asian Americans, it's important to know that Asian Americans look differently. Some Asian Americans look like me, Filipino American, which in other words means, what are you? Other Asian Americans might come from East Asian backgrounds, so Chinese American, Korean American, Japanese American. Others come from South Asian backgrounds, so Indian American, Bangladeshi, and we all look differently. We all walk down the street together. We all might experience different types of racial discrimination because of our phenotype. So that's one thing that's really important for us to know, is that Asian Americans are lumped into these categories because we happen to be a part of this or come from the same part of the world when we came here to the United States. There are hundreds of religions and spiritual practices that comprise of the Asian American community. There are multiple generations here in the United States. So Asian Americans can be first generation immigrants who come to this country, but there are Asian Americans that are up to 6 or 7 generations here in the United States. We have various immigration experiences. So a lot of us come from post-1965. The Immigration Naturalization Act of 1965 allowed Asian Americans to come to the United States without quotas, as they previously were restricted to before. And then there are other Asian Americans who have been here for multiple generations, those who come over as refugees, some who are undocumented. So when we talk about immigration experiences of undocumented Americans, we oftentimes don't think about the Asian Americans that are undocumented as well. And with this heterogeneity also comes the spectrum of sexual orientations and gender identities, understanding how intersectional identities impact our experiences, as well as diversity of social class, socioeconomic status. So you have some Asian Americans that might be stereotyped as model minorities, but we also have a lot of Asian Americans who have higher poverty rates, who have lower educational rates, and they're often not included in the narrative. When we talk about general Asian American cultural values, again, recognizing that we're so diverse as groups, but there are some common values that you could see across different ethnicities. So filial piety, for example, is this notion that people put others over themselves, they're collective as a group, that we often tend to think of our families before our own best interest. Another example is this idea of shame and humility, this idea that we want to remain humble, that shame can often be a reason that might prevent us from seeking proper mental health treatment. The model minority myth, which I mentioned earlier, describes how Asian Americans are often stereotyped to be educationally successful, to be career-oriented, to have very few problems with the law. However, the problem with the model minority myth is that it is a myth, that not all Asian Americans are doing well. And in fact, there are many Asian Americans who are doing quite the opposite of well, that they experience many educational disparities, health disparities, that they also might have difficulties in seeking mental health treatment. However, it's also important to recognize that when we continue to perpetuate the model minority myth, which I even debate sharing with people today, because now I'm talking about the model minority myth, is that we pit people of color against each other, and that we often say that Asian Americans are good, or we have to be like Asian Americans, when in reality it's false, and it also pits us against each other. So in terms of mental health issues, it's just important to recognize this idea that cultural shame and stigma might be reasons why Asian Americans don't seek mental health services. What ends up happening is a lot of Asian Americans will somaticize their physical health issues instead of recognizing that it might be mental health related. Asian Americans tend to be emotionally restricted, particularly East Asian Americans, because of this idea of not being able to express when you are in times of pain or distress or despair, because it's not good for the family to recognize that. A lot of Asian Americans will turn to spirituality and religious coping mechanisms as a way of dealing with stress, instead of seeking help from their primary care physicians or even from mental health services. And a lot of Asian Americans and Pacific Islanders believe in fatalism. So this idea of leaving it up to God, leaving it up to a higher power, instead of taking control of their own life. There have been some common themes with mental health treatment over the past 40 years. One is that Asian American Pacific Islanders utilize counseling services the least out of all racial ethnic minority groups. They seek symptoms when they're most severe, that most providers are culturally incompetent or linguistically incompetent when working with these populations, and often that they're misdiagnosed. So issues that are, or symptoms that are common for Asian Americans might be misdiagnosed because they're not culturally congruent with what white American Western standards are. For example, with schizophrenia, Asian Americans generally have similar statistics when it comes to schizophrenia, but it just might manifest differently because of cultural bound symptoms. What I really want to emphasize is that there are lots of ethnic disparities that we need to recognize among these different groups. For example, when disaggregating data, we find that Vietnamese Americans in California were twice as likely as whites to report mental health problems, but less likely to discuss such issues with their physician. We see that depression is higher among Filipino Americans than the general American population, and Filipino Americans have higher levels of schizophrenia than the Asian American population as a whole. And for Native Hawaiian youth, that they have the highest rates of substance abuse in Hawaii in comparison to all racial and ethnic groups. So how do we address all these things? We know that there are things that we can do on individual levels to normalize mental health treatment. I know it's very common for me to have to do a lot of psychoeducation with Asian American students, Pacific Islander students, to let them know that what they're going through is normal, that it's normal reactions or response to stress as well as to historical trauma and to everyday stressors. That on community levels, we need to discuss mental health issues in all of our organizations, in our churches, in our families, instead of waiting until it's too late. And on national levels, we really need to advocate for Asian Americans and to include them in the conversation. When we think about people of color and communities of color, oftentimes Asian Americans are the last group that people don't think about, or because of the model minority myth, they tend to exclude us. But we are also here, we're part of the conversation. And so I'm over time, so thank you very much.
Good morning. Thank you so much for joining. I am grateful for this White House initiative, for the American Psychological Association, for the Department of Health and Human Services, providing this important opportunity for us to talk about health disparities. Dr. Maya Angelou penned the words, "Out of the huts of history, shame, I rise. Out of a past that's rooted in pain, I rise. Bringing the gifts that my ancestors gave, I am the hope and the dream of the slave. I rise." And so it is so important as we think about discrepancies, disparities, and discrimination that we also recognize the resilience as a part of the reality and the fabric of African people living in America. We are 13.2% of the U.S. population, 45.7 million people living here who identify as Black or African Americans. That includes those who came as a part of the transatlantic slave trade, as well as those who immigrated at later times from Africa, from different parts of the diaspora, the Caribbean and South America. A part of our reality is what is referred to in the literature as historical trauma or intergenerational trauma, and so recognizing the realities of historical and contemporary manifestations of racism. That includes slavery, sharecropping, and how those things affect our health, our educational, social, and economic resource denial. In today's times, we think about police brutality, we think about community violence, and we think about hate crimes that have even intensified after the election. All of those things translate into socioeconomic disparities, and those affect our mental health today. And so when we're working with mental health issues for African Americans, we have to pay attention to the socio-political context. There are physical health disparities that affect us as well. And so when the communities cry out Black Lives Matter, they are also saying Black bodies matter, Black minds matter, Black families matter. And so recognizing holistic health and how our bodies affect our minds, we have to acknowledge that we are disproportionately affected by diabetes, by prostate cancer, breast cancer, heart disease, hypertension. Our children are more likely to experience asthma as a result of environmental racism. Our men and women, our youth and elders are more affected by HIV and AIDS. We have higher rates of infant mortality and higher rates of stroke. While we are not more likely to be diagnosed by all cancers, we are more likely to die from cancer as a result of being underserved. It's also important to recognize that Black mental health matters and what are the challenges that our community faces. 20% more likely to report serious psychological distress than adult whites, and so what it means to be walking around in these United States in a place of trauma, in a place of stress, in a place of distress. While we are less likely to endorse low self-esteem because we are often socialized to speak about how we love ourselves, despite that reality, we are more likely to endorse feelings of sadness, hopelessness, and worthlessness than adult whites. This is not just a matter of it being in our minds, and sometimes therapists are trained to just pay attention to what's in the room, but what's outside of the room and what's around us is also what's affecting what's happening within us. We are not more likely to commit suicide. Actually, whiteness is a risk factor for completed suicide, but amongst our adolescents, we are more likely to attempt suicide, and so we have to pay attention to these cries for help. We are also more likely to be victims of serious violent crime than our non-Latino whites. We have higher rates of sexual assault. There are discrepant findings, but some find that we are at increased rates of intimate partner violence. We are more likely to experience community violence, and we are at increased risk for human trafficking, particularly sex trafficking amongst African American adolescent girls. This relates to our manifestations of post-traumatic stress disorder. It also relates to the disproportionate ways in which our youth are diagnosed with ADHD. When we control for trauma history, then we see a great decrease in the discrepancy of our children being labeled as ADHD. In terms of how we manifest our symptoms, often African American women will show their depression as irritable depression. And people are more sympathetic when you show up looking sad. But when you have, quote unquote, a bad attitude, people don't have a lot of sympathy for recognizing your sadness is showing up in your attitude. And so it's important for therapists to be tuned into that. Black or African Americans are also twice as likely as non-Latinos to be diagnosed with schizophrenia. We are more concerned about the stigma associated with mental health and seeking mental health services, especially among African American men. In our community, there is an idea that if you seek therapy, that you must be, quote unquote, crazy, or you must not have friends, or you must just want to waste money. And so we have to address this issue of stigma. There is also increased distrust. In the literature, we talk about healthy paranoia and the importance of recognizing when I am not trusting systems that have been shown to not care about me, there is a health factor that is related to that. We are more concerned with being pathologized. We have economic, cultural, social, and psychological barriers to help seeking, less likely to acknowledge psychological problems. They're usually named as a spiritual problem. And so we would say, pray for me, I'm going through a storm. I'm climbing up the rough side of the mountain. God knows my heart. And so because of all of these challenges, there's a miseducation and a lack of education regarding mental health disorders. Access to care is another challenge. As we've heard earlier, the Affordable Care Act has helped us in terms of increasing insurance, but there are still challenges with that. We are less likely to receive services around our depression or around substance dependence. We have to also acknowledge the realities of the prison industrial complex and recognize the pipeline that leads our children to being disproportionately incarcerated. And I think all mental health professionals would agree that locking people in cages is not helpful for wellness. Homelessness is also a factor that keeps us out of mental health facilities. Higher rates, not of addiction, but higher rates of arrest related to our addiction and the realities of self-medication. We have lower numbers of African American psychologists and psychiatrists. Much provider bias is in our industry and a lot of misdiagnosis. A neglect, as Kevin was saying, of intersectionality. And so the need to pay attention to within the African American community, gender, SES, sexual orientation, disability, migration status, religion. And there are disparities with a lack of research. Finally, in terms of solutions, it's important to pay attention to our strengths. So our cultural strengths, race is not just about racism, but what we bring to the table. And so what are the ways that we have healed through faith, family, and community support? And so if we can collaborate with these factors, we can improve our mental health. Empowering African Americans to assess the cultural competence of providers so that they do not end up being harmed. Advocacy for clients and communities to address the issues beyond mental health, poverty, discrimination, and mental health care access and funding. To address the needs for violence prevention and mental health interventions. And finally, a need to increase the mental health literacy and quality control efforts that are facing our communities. In closing, as we look at discrimination and disparities, the question is asked, who will sing an upbeat black girl song? Who will sing an upbeat black boy song? We will sing it for ourselves, and the world will marvel at how long we hold our notes. Thank you.
Good morning. And thank you everyone for being here. I'm very excited to be able to share the panel with such wonderful scholars. And it is exciting that we're having this very necessary conversation. I know that my time is limited, so I'm going to get going. And I'll let you keep time of this. This is not letting me do it. All right, so we'll start off by saying that, of course, we're going to go through a number of things. I'm going to move through this, but ultimately highlighting the disparity of mental health and the challenges that Latinos have to overcome, and what are some practices that we can consider. Before I start on this slide, I'll basically be able to tell you a little bit about the fact that we are 17% of the United States population. We are a growing minority. Many of us have lots of heterogeneity. People think of Latinos as one group, but we're not. You think of people from the Caribbean, people from Mexico. Mexicanos are the largest, however, at 60%. So you can kind of get a scope of the fact that we are also a very growing but heterogeneous group. With that said, 25% lack a usual health care provider. Most Latinos believe that they don't need a regular health provider, and about 80% of them actually get a lot of their information from the media. I'm often reminded of a story of a colleague of mine who keeps telling her parents, you need to do this, you need to do that, and they don't listen. And then one day she calls, oh, well, you know, Dr. Phil said this, or, you know, what do you mean, Dr. Phil? You know, I've been telling you this for a long time. And so there's this kind of access, right, to be able to go out and look at the TV. And so they're less likely to seek preventive care, more likely to have chronic diseases like diabetes, cancer, HIV. Other problems within our community include obesity, hypertension, heart disease, and many others. But some of the barriers within the health profession include language barriers, citizenship, money issues, insurance, lack of it. Even though we do have the ACA, we still have an issue about 30% of them not having insurance. And even lack of knowledge of resources, right? Disconnection to doctors, and I'm going to talk a little bit about that in a minute.